So my name is Mike McKee. I'm an associate professor here at the Department of Family Medicine here at University of Michigan, and I'm delighted to have everybody here. So this is part of our several training sessions that we will make available in preparation for the standardized patient program. And this is sort of a new standardized patient program in which we are having community members who have different types of disabilities to serve as our standardized patients. So it's really intended to have that lived-in experience to be able to share as they train future medical students. So we are going to be going through several different types of disability training sessions in preparation for the students so that when they actually meet with the standardized patient program or the event, they'll be prepared to hopefully know the best practices for communication, making sure things are accessible. So I am delighted to have this training session that will be focused on deaf and hard of hearing care. And what we'll do is just kind of do a quick introduction for our two panelists, and then I'll have Dr. Stasov start. So first of all, I'm delighted to have Dr. Stasov join us. He's been a lifelong mentor for me, and so I'm thrilled to have him here join us today. And so he was our former chair at the Department of Family Medicine here at University of Michigan, and he's very active. He's so very active, even in retirement, with a variety of projects, travel, and so forth. So he is one of the international experts around disability health, especially for healthcare services for deaf and hard of hearing individuals. So he's really going to be sharing a lot of great insights on what we can do to make it accessible in a clinical level for deaf and hard of hearing individuals. And then Nika Way, we're thrilled to have her join us. So she is one of our standardized patient individuals who's going to be joining our cohort. So we have 7 altogether. So Nika is one of us, one of our group that we're going to have. And she is also an alumna of University of Michigan. She was born and raised in Detroit. And she is also a passionate advocate for disability awareness and equity. And she has a personal hearing loss. And so she will be describing some of her experiences and talk about what not to do, what to do, and how to navigate in a healthcare environment. She's going to also share some insights from the community and some of her personal stories as well. So we're really thrilled to have both of them join us, and I will also share some insights at the end as well. So Dr. Sasso, would you like to go ahead, sir?
Sure. Thank you for having me.
Thank you.
I'm going to share my screen. Thank you for having me, and I'm going to spend about 10-15 minutes just reviewing communicating skills with your deaf and hard of hearing patients. And I should say that you will see these people. 20% of your practices, regardless of your specialty, will have a hearing loss. And it looks like I work with that. Most of those patients will not tell you, but we will talk a little bit about how you can screen for some of them. So I'd like to start with this. What does the word deaf mean to you? I tried this and gone from person to person at meetings and lectures and asked them, and I get different answers. And the reason is because there's no good definition. The WHO defines deafness as hearing loss so severe that amplification doesn't help. I'm going to use myself as an example. You can stand next to me to the side and talk to me. I have no idea what you're saying, but sometimes I can use the telephone. Doesn't make sense, but that's life. That's the fact. Oliver Sacks, a very famous neurologist who had a special interest in hearing loss, came up with 3 levels of hearing loss. And again, you can look at him, but the severe, I'm an example of where that doesn't really describe deafness. There are many variables involved, and there's a wide spectrum of hearing loss. The frequency, the intensity, how old you are when you get it, whether it's one or both ears and so forth. But unlike visual loss, even if you define all of the above, hearing loss still can defy categorization. And Fred Best said about 30-some years ago, which is still valid today, some individuals with mild hearing loss may experience substantial disability and handicap, where others with moderate hearing loss do fine. And I have a profound hearing loss. I've done pretty well, lost the barrier, but I've done pretty well. So it's very hard to define hearing loss, unlike visual loss or other losses. The bottom line is the major issue in the life of a deaf and hard of hearing person, regardless of how bad the hearing loss, is communication with the rest of the world. And again, the major issue in the life of a deaf and hard of hearing person, whether capital D deaf, which is the deaf community who use sign language, small D deaf, who are oral deaf or hard of hearing, is communication with the rest of the world. Many of you probably recognize this. This is the Great Wall in China that women in the right lower corner is my wife, and we went there in 1981 when they first opened to tourists. That was built by the Chinese to keep the Mongols from invading China. If you have a hearing loss, almost everybody with a hearing loss would feel like there's a great wall between them and the rest of society in terms of communication. So what can you do if you have a patient with a hearing loss? What are some of the best communication approaches? And I'm going to list a few here. First, ask the patient what they want. Do they want to do American Sign Language? Do they want to speak? Do they want you to use captions? Well, now, American Sign Language is a distinct language, as most of you probably know, and it's not English in sign. Then the next thing is provide what the patient tells you they want. It sounds very obvious, but we often don't do this. I'm frequently asked to testify or be an expert witness in malpractice cases when the deaf patient is suing somebody, a doctor, an institution, because they didn't have access to appropriate accommodation to understand. The most recent one was a major medical center on the West Coast who actually contacted me for help. The deaf patient there ended up having her gallbladder taken out, and she thought she was having heart surgery. And you wonder, how can they confuse? Well, the reason they confuse, they didn't provide appropriate accommodation. Some places provide remote interpreting. VRI stands for remote interpretation, video remote interpretation versus in-person. And there are some issues with that. Remote is definitely better than nothing. In-person is better than remote. Accessibility in other forms for communication. Mass. When we first had COVID, I couldn't communicate with anybody because I need to read lips. Now we have clear, certified, FDA-certified masks. Every Michigan clinic, even radiology, has those. So you can use those. Look at the person. Don't look at the typewriter because they have to look at your whole face to understand you. Even those with mild hearing loss do that. Have the interpreter placed appropriately. The interpreter should be behind you, to your side, so the deaf person can look easily between you and the interpreter. It's not for you to look at it, it's for the patient to look at. Remember, the deaf and hard of hearing patient may have lower health literacy, that's very common. The average capital D deaf person reads at a 6th to 8th grade level. So do not use medical jargon. And avoid over enunciating. Do not talk like this. People can't understand when you do that. And don't talk too loud. Screaming does not help. Use visual clues and graphics. For example, if you're talking about a knee, I tend to do this so the patient can see in the core, the medial collateral ligament, I can show this. Or you can use graphs or pictures. That's very helpful. Whatever you do, don't dumb down your explanation. People with hearing loss are not dumb, they just have trouble hearing. Feel free, and you should ask your patient their views about their hearing loss. They may not tell you, they may be embarrassed, but they may tell you all kinds of information that will help you in your connecting and communication with them. If there are special things the patients need to do ahead of time, like special parking places, where they have to come into the building or check in, let them know ahead of time. It's very hard when they come and they can't communicate and they don't know what to do. And wherever you are, your clinic or health system or hospital needs a system to identify these patients ahead of time to make sure the accommodations are present. We're lucky at Michigan, in most places, Epic doesn't have it. At Michigan, thanks to Dr. McKee and his group, on the home screen on the upper left corner, it will tell you if the patient has a disability and what accommodations they need. There are some other communication issues that you need to keep in mind. Medication is a common issue. I've had a mother bring her child to me. They had seen another doctor, were giving antibiotics for ear infection. She was putting the amoxicillin drops in the ear. She just didn't understand, and make sure they understand how to take the medication. Particularly the deaf community, but even other people have a lot of mistrust and misdiagnosis because they don't understand the doctors, and the doctors feel like they're communicating well, and they aren't, and the patient has no idea or poor idea. Like I told you, that patient who thought she was having heart surgery and she's actually having gallbladder surgery. Remember the limited health literacy? And captioning on Zoom or Google Meet are definitely better than nothing, but they don't work all the time. They may be delayed, they may be wrong, there may not be a good picture and they can't see you, there may be bad lighting, bad positioning of the person in the screen. Keep all those things in mind if you're connecting with your patients who have hearing loss. And remember, the ADA, the Americans with Disabilities Act, mandates that you provide reasonable accommodation, provided you know about them ahead of time. We often don't do this. Michigan is unique, but many places don't do this. And even in Michigan, we're not ideal. May not provide interpreters or other accommodations that the patient requests. Studies have shown, and Dr. McKee and many others have done these studies, that people with hearing loss often feel their communication is poor, but the doctors say, oh, we communicated very well. Ask the patient if they understand at the end of the visit. Why don't you tell me what you understand? And then we've talked about clear math and interpreters and captions already. Fascinating to me that most physicians are uncomfortable screening for, addressing, and caring for patients with hearing loss. Probably, we're not sure, probably because we have very little training about that in medical school, even though 20% of your patients will have it, maybe even more if you see a lot of older people. Hearing loss is most common in people 55 and older, but there are also other high-risk groups. So newborn screening is now done, I believe, in every state automatically, and the average age of diagnosis of those kids, it's about 1 in 1,000, is now down to 2 to 3 months, which is wonderful because now we can identify them, we can provide a treatment, whether it's hearing aids or implants and training and so forth. So they have an equal chance to be successful. It's done by acoustic brainstem response, ABR, before they go home, and if they fail the first test, they repeat it again as an outpatient. The biggest issue, those patients who are lost to follow-up, they have an abnormal scan in the hospital, they go home, and the parents never follow up. I was actually involved with the state task force in Michigan to try to reach out and find some of these people and bring them in. There are other high-risk individuals besides those who are 55 and older. Those who work in loud workplaces, who don't wear ear protection. If you're in the military, you're very high risk. Those who wear headphones playing loud music are high risk. The American Indian Pacific Islander ethnic group have about a 50% higher risk of hearing loss than Caucasian. So what can you do? The best one is the single question. Do you think you have hearing loss? Very simple. It has a very high specificity. If they say, yes, I think I do, they probably do. It has a reasonably good sensitivity, but patients are often embarrassed and not won't admit it to you, particularly if other family members are present. Audio scopes, I probably would not recommend the otoscopes that have buttons in which you can play different tones, but with the ambient noise, they often don't work. The whisper type, when you whisper in the ear, okay. Tuning forks are probably not very good. Most people use the same tuning forks they use for vibration testing. That's 250 cycles per second. Nobody here gets that range very much. You have to use specific tuning forks that are 500 or 1,000 cycles per second. The best approach is the screening audiogram, but most physicians don't have that in the office. And what do you do if they are positive to any of your screens? Refer them for hearing testing. Find out if they have hearing loss or not. This is another picture from China of that guy in a cowboy hat, 5'7", and he was speaking to that guy with glasses who spoke some English. Again, this is back in 1981, 82, so very few other people spoke English, but everybody gathering around it. It comes to the critical point: communication, communication, communication. I'd just like to list a few other important best practices for communication. Remember, the capital D deaf who use sign language will have different needs probably than those small D deaf who are oral or hard of hearing. And my screen disappeared. I'm not quite sure why. There we go. Looking at directly at the deaf and hard of hearing person when talking. They need to see your face. Don't look around the room or talk with your back to them. Make sure there's good light in the room so they can see you, but don't stand in front of a window because the glare makes it very hard for them to see you. Talk to the patient, not to the interpreter, not to the family. Don't say, ask him or ask her whether he blah, blah, blah. Talk to the patient. Be prepared to repeat yourself a few times. That's part of your communication. Be aware that many mildly deaf and hard of hearing people are embarrassed and they will not tell you they have hearing loss. And you describe if you can, so you can face the patient while the scribe is recording the information. Look, it sounds very basic, but it's amazing to me how most of them are not done. Thank you.
Thank you so much, Dr. Sasso. Nika, would you like to go ahead?
Okay, good evening to everyone. I'm sorry I'm not ready with a presentation like Dr. Vava, but I will definitely share a little bit about what it is and what my experience has been thus far. A little bit, I want to tag along a little bit of what Dr. Vava shared. So, I am what he described as a lower D deaf, hard of hearing. I am part of the Big D deaf community as well, but most of the time I govern my life is as a lower D deaf individual. I too have profound hearing loss, and so as soon as my hearing aids come out, it's a done deal. However, I wanted to share what Dr. Zazoff was talking about in terms of the discovery aid. So a unique thing about me is that I was born and raised in Detroit, Michigan, but I also have a twin sister. And because of this, we are not exactly aware of when my hearing loss came to be. Because if you think about it, twins, what do? You leave the twins with each other. You keep them in a room. If one parent is calling for the other twin, they never see the interaction of the one twin tapping the other twin and saying, Mom is calling you in the kitchen. Go. They only see that I called out and she appeared. And so it's quite possible that I had a hearing loss ever since birth, but I was one of the different ones in which I also had a twin sister that kind of made me alert to things that I wasn't getting audibly. And so because of this, it wasn't until I was in third grade that they did, I don't know, it's been a while ago, but they used to do random hearing tests in elementary school. So they did a hearing test when I was in elementary school, and I completely bombed it. Completely. Just, it was like no question whatsoever that this child really had a serious hearing loss. Um, and because of that, everybody started treating me different, which was why I kind of was one of those that was embarrassed to have a hearing loss at first. It was, we need to move her to the special school. And it was why? It wasn't because of communication effort. It wasn't because she needs to be in a community with others. The main reason why was because we don't have what we need in order to adequately teach this young girl. When until I took the test, I was the top 5 students within the school. So it was automatically assumed that because it was discovered that I had a hearing loss, all of a sudden we no longer can handle you. And that was my introduction to what it meant to be deaf. All of a sudden, I was getting pulled out of class to go and take speech therapy class. To this day, I don't like the audiologist office because of that very thing. I love school, I love class, I love learning, but now this new thing has come about, and now I'm so different from everyone else that I'm being pulled from the things I enjoy. So upon discovery, and then that was all my parents knew. My mom was told, "We're so sorry she has a hearing loss." Or we were told, "Unfortunately, things have to be done differently. Watch your language when introducing this new, different experience to patients and to parents if it's upon discovery." It's not an unfortunate thing. It's not something to apologize about. It's a bit of information that you're sharing. We found out that your child has not passed the hearing test, so there may be other options that need to be taken in place. It's far and vastly different from, "We're sorry, your child didn't pass their hearing test." It really sets the tone and creates the connotation of what they're going to view deafness as. But then as I got older, I got to college, I met so many wonderful deaf individuals, and it was like, actually, this deaf thing is not a bad thing. I picked up American Sign Language, and I was just loving being immersed and accepted and welcomed into a culture that was so much different than what the world was telling me that I had to fix, that I had to change, that I had to adjust in order to fit in. In terms of my role in going to doctors, I love teaching and exposing other individuals to differences and new possibilities and how they can engage with myself and ultimately other patients like me. One of the things that Dr. Zazoff brought up is to talk to the patient. Um, Quite often you go into the doctor's office and it's quick, it's quickness. Okay, you're here for what? Okay, and they're looking at a chart and they're looking at the information and they're barely looking at you. And to me, the way that I interpret when I'm being spoken to, because I lip read, I read the captions, I use interpreters at times, but my main way of communicating is hearing bits and pieces of the sentences while lip reading and catching the rest that I miss audibly. And so if a doctor is coming in, and to me, it looks like they're moving their mouth, they may just be like muttering to themselves as they're looking at the sheet because they're not looking at me. And that can, it's not until I'm looked at that I'm like, "Okay, Nika, pay attention. They're getting ready to talk to you." So if you are one of those individuals that walk in and you're playing catch up with the notes and the chart and trying to make sure, even if you're with a deaf patient, they're probably not going to start paying attention until you look at them and start speaking to them. Another thing is if you are turning around, you're putting the hand sanitizers on, you're putting the gloves on, and you're saying, "Okay, what we're getting ready to do," and you start turning that back and you're talking to the wall, we miss all of it. You're going to have to repeat yourself. we're gonna do the wrong thing. He told me get up on a bed. I'm still sitting in a chair. And oftentimes, because we being the deaf community are used to having to play the what, the hunt, the repeat yourself game, it can get frustrating at times. So we're not going into the doctor's office with joy and this is going to be an easy go in and come out. It's an anticipation of a struggle and a battle to be understood, to understand, and ultimately figure out what's going on. And so when you have a patient that tells you, I'm sorry, could you repeat that? They say, huh? Or they just give you the blank stare. Those are oftentimes indicators that even if it's not shared, that this person has some hearing loss. So communication is not being effective. So alter your ways. If you say the same word, and I'm not even going to try to attempt to say any type of medical term because that's not my field. But if you're saying a word and you're repeating it and it's still not getting through, this is the perfect time to practice finding a word that means a synonym or something like that. It could very well be that my lip reading skills, I don't pick up a lot of the differences between S and P. They give the same lip shape and the multiple words that could fit both of those. And so I may be trying to figure it out, and it's extremely helpful if you use an alternative word, if you use an alternative phrase to get across what it is that you're meaning. Yes, sometimes we will bring family members into the room because the the conversation is just a lot easier with them. However, like Dr. Vazov shared, your patient is the patient, not the family member, not the interpreter, and not, no one else other than the patient. So even if you are witnessing that you're asking a question, the patient is turning, looking to the person that's giving them the interpretation of it, and then they're coming back and looking at you. That doesn't mean you start addressing your question to the other person in the room, because at that point, we are no longer being viewed as part of the conversation. And we're either going to shut down or we just get attitudes and stuff. I mean, if you were in the room and you kept trying to inject yourself in a conversation and you kept being ignored, your demeanor would change as well. And lastly, I wanted to share that any effort is well appreciated. We are not knocking any of the changes that were made. For example, the clear masks are amazing. Sometimes they fog up and they block the lip reading. And so as amazing as they aren't the end all be all for clear communication. The same thing with caption on Zoom. This is the first time I saw my name spelled right on Zoom because we have a cart person with us captioning in real time, but sometimes it doesn't catch all the words. I'm in a whole different conversation based on what the caption picked up because it's not perfect. It's not the end all be all. Interpreters are amazing. However, sometimes interpreters have their own demeanor. Sometimes the communication or the vibe between interpreter and patient isn't the best. And so rather than go through a 6-month wait to get an interpreter and then go through getting an interpreter that doesn't understand you and then going to the OBGYN as a female, but your interpreter is a male because that's the only one they can get, all these things are great and welcome accessibility, but it is not the end all be all. So, for example, as myself, if I wanted to request a Black female interpreter, because that just makes me more comfortable, guaranteed I'm going to have at least a 6-month wait in order to get into whatever the appointment that is. So do I decide to wait until I'm comfortable and accessible in the way that I want to? Or do I just go ahead and go with what I got? So that's the goal. Thank you to Dr. McGee for allowing us to be able to bring these issues up to you, these scenarios. And I believe we'll be here at the end to answer any questions that may come up. Thank you.
Thank you. This was great. I really appreciate everybody's insights and sharing their perspectives. So what I want to really just challenge each one of you is to start thinking about how you can universally apply a lot what you learned from Dr. Sasso, from Nika, in terms of what you should do and what you should avoid. So when you have deaf and hard of hearing individuals, I tell clinicians, students, in a session, you are going to have at least one of those individuals having a hearing loss. So a typical, let's say we just rounded out 10 individuals, you're going to have at least one, maybe even two individuals who are going to have a hearing loss. So people push back and say, well, they're not often, and that's not true. They just are more of an invisible, they're just kind of hidden. Sometimes they're embarrassed, they don't want to disclose. And part of it is the stigma, the negative attitudes that we bring to the table. So it is really critical that we need to screen, we need to get to know our patients better. And so one of the things is doing a disability field or some way to screen for different types of disabilities. The other thing is when you have an individual start the process of seeking healthcare, you need to think about all of the potential barriers. So when they call, sometimes people get screened out as being an expensive patient. It does happen. So when they call through a video relay service, an interpreter, or even try to like voice carryover or different options, you'll hear basically an interpreter saying, I have somebody on the line and they're facilitating communication. Some doctor practices will actually say, sorry, we're full. When in reality, is there may still be a slot available for a patient. So when patients get scheduled, we need to start thinking about screening individuals. Do you have a hearing loss? What can we do to make the visit more positive? These are individuals that have brought decades of mistrust, just feeling, they've had negative experiences, not wanting to come in, knowing it's not going to be pleasant. We heard about that earlier. So we need to change that. So when now they get to the doctor's office, things are already in place. You have an interpreter present. You're already at the front staff. Somebody has a clear mask. So having a clear mask is one of the easiest things that we can do. And we're still going to be masking for quite a while. And so having the clear map is not only one, makes it more personable. Hearing people like it because they can see your face. Children like it, they're less intimidated. And it certainly will help. It's not the answer to everything, but it will help facilitate communication. So why not always do it? And I would challenge everybody to start thinking about it. This should be part of the universal design. We need to make our healthcare more accessible. We need to make it more inclusive. So when they're at the front staff, that process starts to help patients feel more at ease. And then when they actually are roomed, having the nurse or the MA come out to tap. Sometimes people will call out names. I've had that experience where somebody calls out name, I miss it. And then of course I'm always like hyper vigilant, trying to make sure I don't get missed. It just adds another layer of stress. When they get roomed, then that process, making sure you're facing the individual, getting the information that you can actually put into the chart. So as a provider, when I engage my patients, I don't put a laptop in front of me. The laptop is over my left, is on a little table. I'm facing the patient. And that way you can actually have good eye contact. You can see visual cues. If something is not clear, you need to repeat it. You need to change the phrases. You need to change the statements. You also need to be mindful of your patient room. So we have some rooms that are a little bit tight. Patient bed or examination table. There may be a place where there's a computer, there's sinks, chairs. So try to have it where it's more of like a small circle so you can engage people. They can have their significant others. They can have other people be there in support. But as Nika said, face the individual with the hearing loss. They're the patient. We're not looking to the interpreter. We're not looking to their mom and dad, their husband, wives, their friends. We need to face them. When you actually face somebody else and say, oh, tell the individual this or that, what you have done is eroded that patient-provider relationship. You have disempowered the individual. So many of these individuals have already had the experience as a child growing up with mom and dad kind of facilitating and managing the conversation. So make sure that they are the focus so that they can actually be empowered to answer the questions that you have and know what the next steps are. The other thing what we do to help to minimize some of the stress and anxiety is even things that hearing people take for granted. A door knock. You imagine if you're changing in a robe, you're naked, it's also a vulnerable time, and somebody just walks in the door because you didn't hear a door knock. So what we do to minimize that is that we have a door knocker. Knock on the door, a light goes off. That is another way of just trying to figure out how we can minimize some of the barriers, make the visit more comfortable. Now, keep in mind that you heard some examples with deaf signers having interpreters. There are also people who have later onset hearing loss, who, again, they may not be comfortable. Maybe they can't afford a hearing aid. I mean, a hearing aid has already been touted as being the third most expensive thing you'll buy in your lifetime after a house and a car. So expecting people to pony up to $7,000 is unreasonable for many of our patients. So another strategy is when you screen and identify how can we help to make this communication accessible. Sometimes is they will say, I have trouble hearing answer amplification. Assistive listening devices are actually dirt cheap. They're really talking about $75 to $100. A clinic can easily afford it. So having these available so you can give it to a person who is unable to afford a hearing aid. These are tools that might be appropriate for the mild to moderate hearing loss. These are not for people with severe, profound. That is not going to work. So the other thing is that when you're engaging these individuals, you heard Nika mention need to rephrase, restate it, use synonyms, other words. One of the key things when I wrap up a visit, I will kind of give a summary. I'll say, okay, I'm just going to review some of the things that we're going to be doing next. Review the problems, review the labs, referrals, so that they could start to have that process, have it in writing so that they can refresh later. That's a good practice to be done, regardless if someone has a hearing loss or not. The other thing is something called Teach Back. So Teach Back is another useful tool. It does require a little extra time to make sure that they can repeat back to you. They feel that way you feel comfortable and confident that they got the information they needed. So these strategies, communication strategies, are what I would like you to do in the standardized patient program. These are good strategies to do regardless if somebody has a disability or not, regardless if they're deaf or hard of hearing or not. And so when we actually go through these communication principles, we need to make sure that, one, they're accessible, two, they're inclusive. So in terms of, you heard what Dr. Sasso talked about health literacy. These individuals may not know how to get from A to B. It's not because you feel like they don't know well, or they may be dumb. That is not the case. They just have not been able to have the appropriate information. When you look at health information, is it accessible in American Sign Language? I would encourage you to look for topics, a reliable website to see how many videos you can see in American Sign Language. It's pretty low. In some cases, there aren't any information. The same thing, even for somebody who has already had a hearing loss, but maybe speak, the access to listening to videos, radios, and other, all really boils down to, is it captioned? Is the information available? Is the captioning reliable? Is it accurate? So what we have done is completely taken and dismantled all of these information sources that hearing people get all the time. I often use the analogy of like cholesterol, or even talking about the dinner table concept. So cholesterol, for example, when I say cholesterol to a hearing person, everyone gets it. When I talk about cholesterol to a deaf person, not many get it. And part of that was it's incidental learning. You saw Lipitor, a lot of these medications were promoted, advertised on TV for many years, but the commercials were not captioned. And so deaf people did not get that information. They're very well ingrained. Everybody knows it, but the deaf community does not. So don't make assumptions that they do know, but don't dump down for the communication as well. The dinner table is another really powerful concept. When we all gather, this is something I even struggle myself, is that when we gather and they're all hearing, people chit-chatting back and forth, I get lost. Deaf and hard of hearing patients, they get lost too. And so what happens is that I don't hear those little tidbits about health information about family members. So when I ask deaf and hard of hearing individuals about their family members, do you have anybody with heart disease, cancer, or do you have osteoarthritis? Some of them are like, I don't know. And the reason is because of that kind of setup, inaccessible communication, even in their own home. And so that dinner table, what it does, and also one, they don't know about their family history. That makes it hard for me to know if I need to change my screening parameters. Do I need to screen for cancer earlier? And so I often will encourage deaf and hard of hearing individuals, text, email their family member to start kind of catch up and get that information that's missing. The other thing is we hear a lot of incidental learning opportunities about around diet. So you may have, so Uncle Joe, people say, yeah, he had a horrible diet. No wonder why he had a heart attack. That information, we don't really think much of it, but you learned a few things. Bad diet, ended up with a heart attack. And so that starts to basically give additional information that you can bring to your doctor and share with you and say, I know Uncle Joe had a heart attack. I heard bad diet's bad for me. So what do I do? Instead, deaf people, hard of hearing people in some cases don't have that information. And so we're already multiple steps behind. And so it's really important to make sure that you acknowledge that information gap, the health literacy concerns, help them get there. And you have to be patient. It does take time. You might have to have them come back for a repeat visit as well. So I'm gonna pause there. So I would encourage you just a couple of key points that you've already heard. Make it accessible, make it inclusive, be aware of where some of the struggles and challenges throughout their healthcare visit at the different points. Dr. Sasso.
Thank you. That's excellent, Mike. I want to add one point. Multiple studies have shown now that probably over at least 50%, if not more, of patients in the hospital have a hearing loss. They're disproportionately represented in the hospitalized patients, 50% or more. And studies suggest that most of the doctors one, either don't know the patient has a hearing loss, and or two, I'm not communicating well. They're turning around, the nurses are too, they're talking, and patients say, my doctor is here, but I have no idea what they were talking about. I bring that up because those are sicker patients, and people need to be aware of just standard practices. Face the patient, talk normally, ask for feedback to make sure they understand you. It's important for everybody, not just those people who you know have a hearing loss. Thank you.
Thank you so much. Nika, anything else to add? And then we'll open it up for questions and answer time. Anything else?
No, I think we covered it all already.
Okay. We have a little bit over 10 minutes. We wanted to make sure that there's time for questions and answers. Feel free if you don't want to verbalize it or put it, you can certainly put it in the chat and we're happy to answer them. While we're waiting for a couple minutes, so I'm just gonna briefly show because we have a couple students not part of University of Michigan. I'm gonna show the disability field that we have in my chart. And this is could be useful, and I would hope other places can adopt it. We do have a few places where they are being slowly adopted, but we still have a long way to go. So give me a second and I'll pull that up. So this is what we call the disability accommodation tab. If you look at Big Bird, if you scroll down, you'll see disability accommodation on the left, which is called the soy board. And Big Bird has multiple disabilities that are listed. When you select and open this disability field, you'll have different disability types that you can select. It will populate another field, which you can select common accommodations or care needs. And this allows the healthcare team to know a little bit about yourself and also what would make the visit more accessible.
Dr. McKee.
So we have some questions here. Okay, so Kayla said maybe you could share a little bit about best ways to advocate for patients at institutions that are less disability friendly than UM, especially as medical students and early career trainees. Yes, awesome. Yeah. Nika, Dr. Sasso? Nika, you want to go ahead, sir?
That's a great question, and we are unique here because we have several of us with hearing loss who have educated the institution. I'm going to go back. Most places want to do what's right for the patient, and I would focus on that. The best way to ensure that the patient do the best is to provide appropriate communication and accommodation. And you can show them, the screen we have for Epic, if they have Epic, they can get that from Epic, that screen that Dr. McKee showed you. You can advocate for clear mass. You can advocate for appropriate training for the medical student or for what we call mandatory, where people have to complete a short tutorial. It's hard. Sometimes you feel like you're talking to a black hole, but you will have more impact than you realize if you keep at it. But focus on what's right for the patient, I think you will get more support. I don't know what Dr. McKee and Nakia think about that.
Thank you. Nika?
I think you definitely covered advocacy is not an immediate, department-wide change. It starts with one person, it starts with one act, it starts with the intentionality of what you want to do for your patient. So if you are realizing that, you know what, nobody here has a clear map, then that's where you start. You start wearing your clear map. If you're noticing no one here is even asking, do you need any type of accommodation, make that part of your practice and your standard. And those around you will begin to see and notice. And then ultimately those conversations will continue on and go further to the people that can make the actual like departmental change. But the advocacy starts with you. And once you are consistent with it and folks are able to see and observe how much that changes the visit for your patient, you begin to make the change that way. But it's gonna be a long journey and hard work with it, but it's one, definitely worth it. And two, you're like Dr. Zaza said, you're probably more impactful than you realize by being one of the first to start advocating for your patient.
I totally agree. I have a few additional points. One, diversify your team. When you have a diverse team, you have different perspectives, and that also should include people with disabilities that will be able to get it and relate to patients with disabilities, including deaf and hard of hearing. Second, we heard about education. Education is powerful. I'm really excited about the future because of you guys. You guys are learning about it. You're going to create change. The third thing is leverage technology. Technology has exploded. It has really impacted my life greatly. It has also brought down some barriers. It's also increased some barriers. But I would leverage technology to help with a lot of the accessibility and assistive needs. And then lastly, is sometimes you have to fight. Sometimes that requires litigation. Sometimes it requires a patient to complain to the hospital. And sometimes there has to be a negative consequence to create, hopefully, a more positive change.
There was another question, Mike, about non-English speaking patients who have hearing loss. I think we should answer that too.
So,
Definitely.
yeah, Nika, go ahead.
Um, one of the awesome things is that if your non-native English speaker uses a different sign language, so American Sign Language is not universal. And so if your patient is from a different background and they are using sign language, one of the things that could be helpful is having just the alphabet chart in their language. And that could be part of, just helping, starting to spell out words and things. This is also why we mentioned the gesturing, the pictures and the being sure to have the object that you're looking for. Um, it goes a long way to say, how's your heart? And pointing to your heart. Do you have any pains in your head and your knee? And really using your body as part of that communication, being extremely intentional and wanting to open the line of communication in any way possible. Find out what that individual wants. You realize they're non-English speakers, probably non-ASL signers. So finding out what mode of communication they would prefer. Sometimes it's just writing, and it makes for a long visit, but if they want to write, then the writing is the way to go as well.
I would add, this might be one of the few situations where a VRI would be good, a video remote interpretation, if you can find somebody in that sign language or oral language to be the intermediary.
Yeah, so I totally agree. Just be mindful, the American Sign Language is not a world sign language. So many countries have their own sign language. I remember going to a conference called the World Federation for the Deaf and taking the subway to the actual conference. Met a Spanish gentleman who was also deaf, and I wanted to communicate with him. Spanish Sign Language, I had absolutely no idea. I knew a little bit of international sign language at that time, probably lost most of it anyway. I knew a little bit Spanish, and he knew just a teeny bit of English. He did not know American Sign Language. And so you can imagine it was trying to navigate through different language barriers. So just be mindful that different countries, different sign languages is going to be very different, just like you would expect with spoken language. I also have some patients who do come from other countries or immigrants, and that does pose a lot of challenges. And I have worked extensively with the interpreter services to see if we can locate some of these different countries. I'm not going to really name them just because it might be able to identify these people. But some of them are coming from other countries where we do not have a sign language interpreter for that language. And so sometimes we try to figure out, learn from each other. It can be a little crude. We also have proposed that we have an interpreter spoken language. And so, trying to kind of figure out how we can cob with. There's no right or wrong answers. It really just boils down to the attention, trying to figure out how this is going to at least move it forward so there's better communication. Lastly, we often assume a deaf person will use sign language. So you need to be careful with that. That's why it's important to ask the individual. So when you have a deaf or hard of hearing individual, I always ask as my first new patient visit, what is the best way to communicate? And sometimes I'm surprised. I'm not a proponent of writing a note back and forth. I think that's a terrible way. But I have one individual who said, I don't know sign language. I don't know how to lip read. I'm not comfortable with English, but I write English well and prefer to actually have our laptops and go back and forth and type. That was a new experience for me. But the important thing is to have the patient write that. And so ask them, what can we do to make this communication effective? Okay. So I know we're at the end of the hour. I'm happy to stay around for a few more minutes after to talk about disability justice. But I want to first of all thank Dr. Zasov and Nika for joining us today and sharing their powerful stories and their insights. So thank you.